This is the cardiovascular system, chapter 20. In this chapter, we're going to be looking specifically at the blood vessels and circulation. So when we look at the blood vessels themselves, the structure and the function of them, we're going to break the blood vessels into different types. You have the arteries. Arteries always carry blood away from the heart. They have very thick walls, and they have the highest pressure. Arterioles, they are also carrying blood further away from the heart. The diameter is going to be smaller than that of an artery. It's going to slow the blood flow down a bit. It's going to help with the regulation of the blood pressure. The capillaries have the thinnest of the walls. This is the site of where the gas and nutrient exchange actually occurs. And then the venules, these will connect the capillaries to the veins. And then the veins are the blood vessels that return the blood to the heart. They have very thin walls. They have the lowest pressure. So as blood leaves the heart, it's going to flow into the arteries, the arterioles, capillaries, venules, veins, and then the heart again. And that is what this is just showing, some examples, excuse me, of this blood flow pattern, if you will. Leaving the heart, leaves by the arteries. Now, some people will want to say, oh, well, the arteries have a high concentration of oxygen. Only in systemic flow, because with the pulmonary circulation, that blood flow to the heart or to the lungs and back to the heart again, those arteries are very low in oxygen. So that's why I prefer that you learn the arteries, regardless of what the oxygen concentration is. Arteries are always bringing blood away from the heart, and then your veins are bringing it back to the heart. And this is showing the capillaries, where that exchange actually occurs of the gases, the nutrients, and waste products. So you're going to go arteries, arterioles, capillaries, venules, and back to veins. With the blood vessels, there are 3 different layers. This is true of all of them except for capillaries. You have the innermost layers, the tunica intima. It's smooth. The lining of it is very smooth. It's composed of, if I can talk, epithelial and connective tissue. Capillaries only have 1 layer, and this would be the layer that they have. The tunica media is the middle layer. It's composed of smooth muscle. This is much thicker in arteries than it is in veins because the pressure is much greater in arteries than it is in veins. Why? Because the arteries are receiving the blood from the heart, very high pressure coming out. The tunica externa, often also known as the tunica adventitia, is going to be the thickest layer in the veins. It is connective tissue. So this is showing up here in this schematic drawing of the different layers. So the intima, the media, that's smooth muscle, and the externa. So this is an artery. And then over here in the vein, notice that the tunica media is not as thick as what you see over here. But in reverse, the externa is thicker. And when you look at a cross-section or histology slide, because of the muscle layer that is so nice and thick in the artery on a cross-section is going to look round, but the vein's going to look collapsed. It looks like somebody squished it. So this would be the vein, and this is the artery. And this open white area, where they nicely put the labels, that is the lumen. The lumen is the opening. That's where the blood's actually flowing, is in here. So we're going to look at all these in a little bit more detail. The arteries, you have elastic arteries and muscular arteries. Elastic arteries, they have a lot of elastic fibers in them, very large diameter. They can expand and then recoil in response to that blood flow and the blood pressure. Muscular artery has fewer elastic fibers and smaller diameter to it, so further away from the heart typically. The arterial has a small diameter. It's going to help slow down the blood flow, which is going to result in decreasing blood pressure. So as the blood vessels leaving the heart, if you look at, say, the aorta, the largest artery is the largest blood vessel itself in the body. If you follow the pathway, think of like a map, a road map with all, the different roads. And it's kind of like the heart would be a big city like Houston, and you're going to have the arteries leaving and the veins coming back. Those are the major interstates coming into town. Well, as you leave Houston on major interstate, right around Houston, it's multi-lanes of traffic. But as you move further away, you have exits branching off of the interstate. Well, that's kind of like your arteries are getting smaller as you branch, as you extend to service different areas of the body. You branch to feed the kidney, you branch to feed the liver, you branch to feed the intestines. You're going to continue on down, just like that roadmap continues from interstates, then maybe down to a divided highway. Well, now you're branching down into the arteries into, say, the leg. The roadmap, you're going to have county roads branching off. Those are going to be your arterials. And then you're going to have here in Texas, which was new to me, the FM roads, the farm to market. It took me a while to figure out what FM stood for. The smaller routes, country roads, county roads, etc. You have this continued branching into smaller and smaller. Well, the blood vessels, you start with the nice thick diameter elastic artery, and then it's going to branch to the muscular artery that's smaller diameter, and then that's going to branch into the arterioles. And you keep getting smaller and smaller diameter. You do see differences in the makeup of the walls. Notice between elastic artery, the thinner tunica externa, but it's thicker in a muscular artery. You do have these elastic fibers in here. And then look at the arteriole. A meta-arteriole, this connects the arteriole now to the next thing, which is the capillary. The capillary is going to be the smallest diameter of any of the blood vessels. So this is like your dirt country road. The meta-arteriole is going to help regulate the blood flow through that capillary bed where all the capillaries are. It contains precapillary sphincters. These are circular smooth muscles. A sphincter is usually a circular muscle. It's going to surround the capillary where it connects to the meta-arteriole. Usually it's closed, and so blood flows through the main thoroughfare. It's like a vascular shunt. It's open when you need more blood flow to that area, and this will make more sense in this picture. So here's your arteriole right here. This area right here is known as the meta-arteriole. It's the shunt. So here it says precapillary sphincters. So if these circular muscles are closed, the only place that the blood can go is through the thoroughfare right here. So if you need a lot of blood flow in this particular area, this is the capillary bed that has several of these capillaries. So each one of these is an individual capillary. Blood is flowing from the arterial through the capillary bed to the venule. So if there's not a lot of need for blood right now, this tissue still needs blood, but it's just going to flow through the thoroughfare. So normally these are closed. If these precapillary sphincters open, then it would allow the blood to flow all through here. So you would get more exchange occurring in this area. So it just regulates. And right now it's showing it closed. Well, maybe the circumstances in 5 minutes will change and it needs to open it up so it can regulate the blood flow through there. So the capillaries, you see how they're in that capillary bed. That, as I said earlier, is the site. That is where the gas exchange occurs. That's where the nutrient exchange occurs. That's where waste exchange occurs. How does it occur? Because the walls of the capillaries essentially are leaky. There's 3 different types of capillaries. And remember, the capillaries are only one layer, only the tunica intima. So they're only basically one layer thick, so they're very thin so that these substances can leak in and leak out. Continuous capillaries are the most common type of the three. They have the complete endothelial lining. They have tight junctions holding the cells together. There are what we call intracellular clefts, these little openings where exchange can occur. And I have pictures of these I'll show you. It might be a little bit easier to understand with a picture. Fenestrated capillaries, that just means it has pores in the lining, the endothelial lining. And the advantage of having those pores, fenestration means pores, is that it will allow for larger molecules to pass through. This is fairly common in the capillaries that are found in the small intestines and the kidneys. And why is that important? Well, in the small intestines is where most of the absorption of the nutrients from that wonderful food you ate occurs. So you're trying to get that into the blood. So you want to have larger openings so you can get all of those wonderful things in. The kidneys, it makes sense because that is where the purpose of the kidneys is to filter the blood. You want to take out waste products, etc. And so it makes sense to have those pores so larger waste items can also pass through. And the third type of capillary, sinusoid capillaries, these are the least common. They're flattened, they have an extensive intracellular gaps plus the fenestrations. So now you can have a lot of large molecules pass through. These are found in the liver, the spleen, bone marrow, lymph nodes, and some of your endocrine glands. So, like I said, this might be a little bit easier to see with the drawing. So here is the tunica intima, that endothelial layer. These clefts, that's just the connection points between cells. So here's one cell, here's another one, here's a third cell. You have a basement membrane around it like you normally do. That connects the epithelial tissue to the underlying connective tissue. So things can pass between these intracellular clefts. They can move out. The fenestrated, now you've got all these pores in here. So you can see how larger things in a higher quantity can pass through. And then the sinusoids where you have these extra large openings. So we've talked about the arteries, the arterioles, the capillaries, and now the venules. The venules are going to connect the capillaries to the veins. So now it's kind of like you're heading back towards Houston, you're heading back towards a big city. So you got off the country road, now you're starting to head on the divided highway. You're getting a little bit larger. You have all these incoming roads. So you're going to have all these capillaries feeding into the venules. So the diameter is a little bit larger to accommodate all this increased blood flow as it's heading, now starting to head back towards the heart. So the venules flow into veins. So now you're on the interstate. You've got all these highways coming in, all these entrances, on-ramps coming in, feeding in. So the diameter is going to get larger and larger. The veins return blood to the heart. Now their walls are thinner than arteries. There's lower pressure, so you don't have to have that thick muscular wall. The lumen, as we saw in that one cross section, that opening where the blood actually flows, is large. It's irregular. Veins often contain valves. Because there's less pressure, the arteries, the pressure is higher, so it's constantly, as the heart's beating, forcing the blood in one direction. Well, the blood pressure is decreasing by the time you get to the veins. So how do you prevent backflow? How do you prevent that low pressure, the blood from going the wrong way? You have valves, and the valves help keep the blood flowing in one direction. If you've ever donated blood or had to get a blood sample taken, let's say in your arm, and they clean the arm, and you notice how the technician is always, she's trying to, he or she, they're feeling around the vein. You ever wonder what they're doing when they're kind of feeling around? They're trying to feel for the valves. You can feel them, and you don't want to stick the needle through a valve. So they're trying to find the valve. So, because like I say, you can feel it. It feels like a little bump, and you don't want to go through it. You're getting your placement correct, hopefully. So with your venule, notice smaller wall. Now you're increasing larger and larger, or thicker and thicker as you get to larger and larger veins. And then notice here, this is showing the cross section with the valve there. This is just showing that the circulatory system acts as a blood reservoir and how the veins themselves are a reservoir. When you look at the circulation and percentage of where the blood is, only at one particular time, only about 7% of the blood's in the heart. About 9% of it's in the pulmonary circulation, 84% systemic, which makes sense because, I mean, pulmonary, you're only talking about to the lungs and back. Systemic is everything else. But notice here that the majority of this 84%, the majority of it is in the veins. And they even have that broken down. In terms of blood flow, that's referring to the movement of the blood through the vessels. Resistance is anything that's going to slow that blood down, that flow of it down. Blood pressure is the force that's exerted by the blood on the walls of the blood vessels or in the heart chambers itself. Usually you measure blood pressure in the brachial artery. When you look at blood pressure, and we're talking about arterial blood pressure because you're measuring it in the artery, systolic pressure is the top number. It is, excuse me, the pressure from the ventricles contracting. So they're forcing that blood out. Diastolic pressure is the bottom number, and that is the pressure during ventricular relaxation. So they used to always say average pressure should be around 120/80. Now they're kind of saying 110/70, whichever number you want to use. We'll average it. We'll say 115/75. So the systolic pressure would be the 115. The 75 would be the diastolic pressure. Pulse pressure is when you take systolic pressure minus the diastolic pressure. So in this case, you would go 115 minus 75. The mean arterial pressure, which is abbreviated as MAP, is the average pressure in the arteries. And so this graph is just showing the systolic pressure, the diastolic pressure, and it's comparing. It's really kind of neat to see as you go through the aorta, which has high pressure, the elastic arteries starting to decrease, muscular arteries going down, and the arterioles, notice now is that pressure, and this is the mean arterial pressure. Capillaries, by now, we're definitely going down. The venules, medium, large, and look at the vena cava, superior vena cava and inferior vena cava. It's where the pressure is the lowest. So when you measure blood pressure, you're measuring it in the artery. Just FYI, when you do a venipuncture, when you have to take a blood sample, it's called a venipuncture. I had someone ask me about this before. Because you're puncturing a vein. And why do you draw blood from a vein instead of an artery? There's a few times where they have to do something with an artery and you really have to know what you're doing because the pressure's so high. You're taking blood from the vein because look how much lower the pressure is. It's not going to be squirting out at you. That's also just FYI, if someone does have an injury and they have lacerated or cut a blood vessel, if they have cut one of your major vessels, number one, you better stop the bleeding right away before they bleed out. If the blood flow is continuous, then you have severed a vein. If it is squirting, kind of a rhythmic squirting, that's because of the pressure, and with the pumping of the heart, that means you've severed an artery. Just these lovely little tidbits for you. The pulse, this indicates the heart rate, and you'll measure this on an artery. Probably the most common place is going to be the brachial artery. You can also do it on the radial artery right here, the carotid artery. Once again, a lot of you I know have clinical experience. When you go to measure the pulse, do not use your thumb because you're going to pick up your pulse, not the patient's. So, to measure the blood pressure, this is usually covered in a lab that we do, but just briefly here, you're going to need the big man thermometer and a stethoscope, otherwise known as your stethoscope and your blood pressure cuff. To get the most accurate readings, you're going to want to use a manual one. Once again, a lot of you I know have some clinical experience, and some of you are very familiar with. At home, you may have a automatic wrist one. Those usually are not in a clinical setting going to be used. This is much more accurate to do it the old-fashioned way. The first sound that you hear is the systolic pressure. The second sound is the diastolic pressure. So there can be multiple sounds, but when you pump the cuff up, that first sound that you hear, this is the cuff pressure as it's decreasing, so you pump it up. And that first sound that you actually hear, that's why you have to be paying attention, is notice the number. So this would have been at 120. It's going to sound faint, and then it gets louder and louder, continuous, and then it drops out. And you have to be paying attention to catch that last sound. What are things that can affect the blood flow and pressure? Things such as cardiac output. Anything that increases cardiac output will also increase pressure and flow. Compliance, that's the ability to be able to expand to accommodate increased volume. If you're not compliant, then you're going to increase the pressure and you'll decrease the flow. I mean, if you can't expand to allow more blood flow through, then it's kind of like that's your stopping point. That's your, everybody's trying to get out that one door type thing. So it's going to increase the pressure and decrease the flow. Blood volume. If you increase blood volume, you're going to increase the flow, which makes sense. Typically also going to increase pressure. Blood viscosity, that's how thick the blood is. If you increase the viscosity, you're going to increase the pressure, and that's going to decrease the flow. Think of, sometimes I'll describe it kind of like a milkshake. The thicker the milkshake, the harder it is to, suck it up the straw. Blood vessel length and diameter. The longer the vessel, the increased resistance. There's more distance to travel with that resistance on the walls of the blood vessel. It's going to decrease the flow. If you increase the diameter, that's going to decrease the resistance and increase the flow. So you have to look at all of these different factors, and this compares the vessel diameter and comparing your different arteries, the capillaries up to the veins, and the diameter. So you can see the diameter is lowest with the capillaries here. If you look at the total cross-section area of the vessels, and combine them all together, the average blood pressure, and then the velocity of the blood flow. So definitely see how it slows down when it's going through the capillaries, which makes sense because you want the blood to slow down as it flows through that capillary bed. If you slow it down, you get increased exchange occurring. If it goes too fast, if it's flowing too fast through the capillaries, you're not going to have good exchange of the gas, nutrients, and waste products, etc. Excuse me. And so this is showing what happens if you have a normal artery right here as an example, with the normal blood flow through here, the cross-section of it. You can have nice flow. Now, when you have plaque, build up a plaque in your arteries, what does that do? It narrows down the diameter. That means it's going to decrease the amount of blood flow, and it's going to increase the resistance along here. Look at how much it has narrowed. So now the heart has to pump more frequently and harder to get the same volume of blood to where it needs to go. And this is a cross-section of what plaque looks like in an artery. With your veins and the venous system, things that are going to help the blood flowing along through here. Like we said, the pressure is going to be lower than in the arteries. And there are things or factors that will help increase the ability of the blood to keep flowing through there and not backflow. You've got your skeletal muscle pump. What this refers to are your skeletal muscles that are surrounding the veins. They contract. Your skeletal muscles, just even keeping, posture. You've got some muscles contracting, others relaxing, and it's always kind of changing around a bit for that muscle tone. Well, every time the skeletal muscles are going to contract, that increases pressure in the veins and it helps to push the blood up. The respiratory pump. This deals with changing pressure. Every time you inhale and exhale, it's changing the pressure in the thoracic cavity. That's going to help promote blood flow, returning to the thoracic cavity area, which is where the heart is. Everything wants to naturally go from high pressure to low pressure. Excuse me. The valves that we've talked about, they help to prevent backflow. So there's a natural pressure gradient that's driving the blood back towards the heart. Like I said, things want to go from high to low. Well, if it's highest in the arteries, lowest in the vein, the blood's naturally going to want to be going in that direction. And constriction of the veins, venoconstriction, that increases the pressure, and that's going to help increase the flow back. So this is a nice picture showing with the skeletal muscles as they contract. See how it, for lack of a better word, it's applying pressure or it's squishing the veins a little bit, pushing up. It's kind of like squeezing, I don't know, a tube of toothpaste or whatever. You squeeze on the bottom and it's going to squeeze it up towards the top. Here's your valves, so it's closed. Now you squeeze, this blood's going to go up here, then the valve's going to close. The blood that was here moves up, moves up, moves up. It's kind of like a stepwise movement. With capillary exchange, blood flow is just a mass movement of substances in and out of the capillary beds. Couple terms to keep in mind. We'll talk about filtration and reabsorption. This will come again when we talk about the urinary system and function in the kidney. Filtration refers to movement of substances out of the blood and into the tissues. Reabsorption is going the opposite way. It's the movement out of the tissue of substances and into the blood. Movement is always going to be down the pressure gradient, so it's always going to go from high pressure to low pressure. Hydrostatic pressure and osmotic pressure are two of the pressures we talk about with capillary exchange. Hydrostatic pressure is the pressure of fluid that's enclosed in a space, and it's going to force the fluid out of the capillary and into the surrounding space. Osmotic pressure, that's determined by osmotic concentration. What are the concentrations of things? Like sodium, what's the concentration of calcium? What's the concentration of potassium? It's going to draw fluid back into the capillary. So hydrostatic is going to help move fluid out of the capillary. Osmotic pressure is going to help move it back into the capillary. So right here, you're noticing that filtration, like I say, here's your capillary. Filtration is responsible for the moving things out. And notice that the pressure is higher inside, so that's why it's lower outside. It's going to move out. Now, about the middle of the capillary, pressure is about equal, so there's no net movement. By the time you get down towards, over here would be the venu, towards the end of the capillary bed, now the pressure is lower and you're going to have reabsorption occurring. So now substances flow back in, which makes sense. So as over here is the arterial, the blood's flowing in. Initially you have filtration, substances moving out of the blood, meaning your oxygen, your nutrients, things that the cell needs, it's flowing out. As the blood continues now to move down, by the time you get to the end of the capillary bed, you have reabsorption. You're pulling in the carbon dioxide and the other waste products before the blood leaves the capillary bed. So it's like deposit the goods, pick up the waste. And that's exactly what's happening here. So the blood comes in, leaves through, if these were open, you have blood flowing through the capillaries, and even in this section here, flowing out. So you have filtration, things flowing out, those nutrients, the oxygen, nothing much happening right here towards the middle. And then by the end here is where you have the reabsorption occurring. You're taking up the waste products prior to moving into the venule. Same thing's occurring down here. Filtration, nothing, reabsorption. Now, if you notice on there, you spend a lot more time filtering, having things leaving the blood. More fluid is leaving the capillaries than what you return at the end of that capillary bed. So you have more fluid leaving than what returns. So what happens to that excess fluid? Well, we don't all swell up like a balloon, thank goodness. So what happens to all that excess fluid? It's going to be drained by the lymphatic capillaries. This is part of the lymphatic system, which ultimately is going to return that fluid to the blood. And then this picture, it's a nice picture showing here's the arterial, blood's flowing this way. Some of it comes down here through this entire capillary bed. Excuse me, so you have your filtration occurring, all that fluid's leaving. And then back over here is where you have the reabsorption occurring. The green are your lymphatic, what we call the lymphatic capillaries. They are absorbing all this excess fluid that did not get reabsorbed here. And we'll study that separately, just very briefly. Know that's like a one-way system. The fluid, once it's in the lymphatic capillaries and these lymph vessels, we call it lymph. So it's very similar to the plasma blood. It just doesn't have red blood cells in it. And it will eventually be returned to the blood because you want the blood volume to remain overall relatively constant. Now, the amount that's flowing to a particular area may change a little bit depending on circumstances at that particular moment. But overall, the blood volume needs to remain about the same. So how do you maintain that when you're losing more fluid in the capillary beds than you're reabsorbing? It's due to the lymphatic vessels. So how do you regulate the vascular system to help you maintain homeostasis? This can be done by neural regulation, endocrine regulation, autoregulation, and resource allocation. And this busy chart kind of shows some of this. Autoregulation up here, just resting normal conditions, going to redistribute the blood as it's needed, depending on what's going to happen here. If oxygen levels decrease, carbon dioxide levels increase, you're going to start to relax some of those precapillary sphincters. You're going to increase blood flow. You're going to have these are vasodilators, so they dilate the vessels till you restore homeostasis over here. If you want to take a look at neural mechanisms, blood pressure, there's going to be different centers that are regulating this. Whether it's sympathetic, it's going to increase, parasympathetic decreases. Blood chemistry, it's going to be looking at different things such as norepinephrine, acetylcholine levels. The endocrine system, there are various different hormones that can be released that can help to restore homeostasis. Remember, everything is about homeostasis, keeping everything in that nice balance. Neuroregulation, there's several different cardiovascular centers in the brain. One of them is the medulla oblongata. It responds to changes in blood pressure. It responds to changes in oxygen concentration. A big stimulus is carbon dioxide concentration and hydrogen ions. And it will adjust the heart rate depending on what these levels are. Baroreceptors, these are stretch receptors. So there are vascular baroreceptors in the aortic sinuses and carotid sinuses. There's also some in the vena cavas and in the right atrium, and they will adjust as well. If they're stretching too much, then they make those adjustments on the heart rate, which is also going to adjust blood pressure. Chemoreceptors are monitoring concentrations, once again, of oxygen, carbon dioxide, and hydrogen ions, and will make those appropriate adjustments as needed. If you have increased blood pressure, that's going to increase or stimulate the baroreceptor firings. You're going to have an increase in cardiac inhibitor centers, decrease cardiac accelerator centers, decrease vasomotor centers. What is all this going to do? Decrease your cardiac output, which is your heart rate and your stroke volume. Increase vasodilation so that the blood pressure drops. And the reverse happens if you have decreased blood pressure. You're going to want to increase that cardiac output. You're going to want to increase vasoconstriction so that the blood pressure increases. Endocrine regulation. Epinephrine and norepinephrine are going to increase the heart rate. Those are both usually released by the sympathetic nervous division. Antidiuretic hormone, this is going to trigger reabsorption of water in the kidneys. That's going to increase the blood volume, and in turn that will increase pressure. The renin, angiotensin, aldosterone will increase blood pressure. It will increase the blood volume. Erythropoietin stimulates the production of red blood cells. That in turn increases your blood volume then. The atrial natriuretic hormone produces or promotes the loss of sodium and water. That's going to result in decreasing blood volume and decreasing blood pressure. And so this chart shows, for the as an example of decreasing blood pressure or decreasing blood volume, long-term, short-term. What's going to happen? Short-term, activate the sympathetic nervous division. Remember your fight or flight, that's going to release epinephrine, norepinephrine. That's going to increase cardiac output. That's going to increase your peripheral vasoconstriction. In turn, those will increase in an increase in blood pressure. So it restores it. For long term, if you have decreased blood pressure long term, it affects the kidneys are going to start to release these two hormones, which then activate the antidiuretic hormone. That's going to stimulate thirst. You're going to increase over here the red blood cell formation. These two things together increase the blood volume, which is also then going to help restore back to the appropriate blood pressure, appropriate blood volume. What are the effects of exercise on vascular homeostasis? I think a lot of you probably are somewhat, familiar with this. With regular exercise, that's going to increase your heart function. It will increase the size and mass of the heart a little bit, not too much. It increases the efficiency of the heart. It will help to reduce plaque formation, which, remember, that's that buildup of plaque in the arteries that slows the blood flow down, causes more resistance, etc. So it helps to reduce that. It helps to reduce blood pressure. And overall, all these combined, it helps to reduce the risk of heart attack.